fine. But let us take help of this attenuation of the thickening to further narrow the differential. And otherwise, your findings are absolutely fine. There is fat standing, there is locule. So, if you go back to your histology, this is the histology of the stomach. This is the mucosa. Then there is submucosa, then muscularis, subserosa, and serosa. Serosa is the peritoneum, the visceral peritoneum. Now, this is the case which I was showing you. Look at the attenuation inside, and as you know, something which is enhancing here, let me change my mouse to arrow, which will be better for you people. Now, if you see, look at this mucosa and develop your eyes on this. Mucosa is showing enhancement. And look at the submucosa, look at the density. And as you have pointed out, this is low density. And low density means water, think water, right? And when you see this kind of finding, this is more in keeping with inflammatory or infectious conditions. And on the other hand, when there is some enhancement, soft tissue density, more likely to be neoplastic, like carcinoma, lymphoma, or metastasis. So this is not an absolute specific discriminator, but a useful tool on a CT scan. So this is another example just to make the same point, that this is a ulcer which has perforated because there are locules here. And again, in the submucosa, you can see low density. On the other hand, this is a case of carcinoma. And if you can see the mural thickening and look at the density there, and you will agree that the density is high. Okay, candidate 2, spot diagnosis. What is this?
Duodenal diverticulum.
Right. Which part of duodenum is this?
Second part.
Second part. Now, duodenal diverticuli can be at various locations. The most common is the second part, and they project towards the pancreas. And you must have seen them so commonly, you know, on a CT scan or MR. So it is nothing important clinically, but having said that, if a gastroenterologist is doing an ERCP, they have to understand that there is a diverticulum. You don't want them to go in. So this is an MR scan where you can see fluid level, and you are worried what is happening. Once you know that there can be a diverticulum, it's easy. And this is a coronal CT scan of the same patient, because the cut is going posteriorly in the dependent portion. There is a bit of debris inside. Clinically speaking, it's not very important thing, but the only thing is that you should understand so that you do not mix it up with any other condition. Okay, I will, because of time factor, now we are going to, okay, you take, tackle that as your last case, candidate 2.
So this is a contrast.
Before you continue, all of you, can you please listen to this very carefully? Because I am going to teach you something here which is very important for your exam. It's a very difficult one, this one. And this concept, because you people don't do bariums, still comes in the exam. So I'm going to do a bit of teaching, taking the help of this case. So please concentrate on this one. Over to candidate 2.
So this is a upper GI contrast study with a spot image project of the duodenum. There appears to be some narrowing of the second and third aspect of the duodenum, and the space surrounding the, or the inner space surrounding the duodenum appears to be slightly expanded. I wonder if there's a mass which is compressing the second and third part of the duodenum externally, and in this location I'll be concerned about the pancreatic head mass which is causing stenosis rather than an intrinsic mass within the bowel. So my primary diagnosis would be a pancreatic head mass which is compressing the second and third part of the duodenum externally.
Excellent. You can mute yourself. Candidate 3, be mentally ready to raise your hand, but I'm going to do a bit of teaching on this case. Now, this case, I'm just showing you because maybe 25, 30 years ago, this case was an exam case. Now, nobody is expected to show you. Basically, what is happening, as you have picked up, that there is an extrinsic mass which is infiltrating the duodenum. And extrinsic mass which is infiltrating is causing some findings. Now, nobody in this era should show you a barium study for this, obviously, and no pancreatic carcinoma should be. This was known as a reverse 3 sign. If you see here, there is an extrinsic impression here. You can understand that the ampulla is here and other bits is here. But if you look carefully, this also tells you when an extrinsic mass is next to what we call a lumen, may it be duodenum, stomach, large gut, etc. What will happen that there will be an impression or compression, extrinsic compression. Then what happens is that these masses, they produce a bit of desmoplastic response, fibrosis. And you can see these spikes of barium, they are projecting outward into the mass. So this is quite, sometimes you might even see that the mucosa here might be fixed. In your exam, again and again, a few cases come in this category. I don't want to tell you more. I am going to show you a few cases. Now, is candidate 3. Can you raise your hand, please? I think there is a technical issue there. So I will go to candidate 4, please. Please raise your hand, candidate 4. Actually, now I can also see candidate 3. Candidate 3, yeah, I am with candidate 3 now. So candidate 4, please wait.
Yeah, I'm here.
Now, what is happening here in the colon? This is a barium enema examination. What is happening? How will you describe this?
This is a double contrast study of the enema of the colon, showing irregular mucosal thickening with loss of normal mucosal pattern and luminal narrowing of the transverse and I could spot there are few ulcers in the colon, in the descending colon, mostly representing in the form of retained contrast. So I'd be worried about neoplastic process. Mostly could be secondary to inflammatory bowel disease due to the presence of those ulcers. And I'll take the case further. I'll do CT for better assessment.
Okay. If you see here, this is a case of candidate 3. I'm going to mute you. There's a bit of disturbance coming, so I'm muting you. Now, if you see there is a barium enema film. On this barium enema, there are multiple diverticuli. That was not the point of discussion. Now, if you see here, this is the transverse colon. On this transverse colon, there is an extraneous compression or impression. So something is sitting outside. And if you look carefully, there are some spikes of barium which are going outside. So something is sitting here. Now, if you look carefully, there is something here. And I am again with candidate 3.
Yeah.
What do you think is this? What do you think is this?
This is linitis plastica, the stomach shadow.
Okay. So now, if you see here, this is a barium meal examination or follow-through examination of the same film, same case, where now you understand what is happening. There is loss of distensibility of this stomach, which is classical for linitis plastica. But the teaching point here or learning point is that how it has caused external or extraneous indentation of the transverse colon. Now, with these two examples, I am now showing you a case which has come in the exam many a times, and even now is a sort of an exam case for you. Can you tackle it, candidate 3?
This is a double contrast barium enema. I can spot that there is extrinsic compression of the sigmoid colon with mural irregularities. I could see surgical clips. There is narrowing of the colon as well with so I think that might be, if this is a female, I would think of endometriosis as the cause of surgery.
71-year-old?
Yeah. Other possibility.
Excuse me, your thinking is good because you are thinking on what kind of surgery, right? So I'm giving you a 71 years old previous pelvic surgery. Over to you.
Maybe colonic cancer, for colonic cancer, or
so this is a female.
She is a female. Hysterectomy might be the cause.
Okay. So conclusion, what is happening here? What is happening here?
I think this is an extrinsic compression from the nearby uterus, secondary to recurrence, maybe, or fibrotic.
Okay. I'll take over. This is a case of classical exam case. Many times it has come in the exam, and similar case will also come in MR, where there is metastasis sitting here, and this is a case of ovarian carcinoma which has recurred. And what happens when metastasis, this is the rectosigmoid junction, close to that. When metastasis will sit here, this is the same phenomena which we saw on the pancreatic carcinoma film. So it will cause extraneous impression or compression here. Now, if you see, there are spikes and it will cause a bit of fibrosis. So spikes of barium will go into the mass. If you stretch your imagination, this is where it must be sitting, and this is where it must be sitting. If you see the mucosal folds, they are abnormal and they become actually fixed. And there is a sign in old radiology which we call striped colon sign. So these mucosal folds, they become fixed there. So this is a film of metastasis from ovarian carcinoma. Now, I will just show you a film to tell you so I am now projecting a case of ovarian carcinoma metastasis, and candidate 3, I hope you can see my screen, right?
Yeah, I can see it.
Okay, so I will continue with my teaching point there. Now, if you see here, this is the rectum. Now, this is the rectosigmoid. And you can see this intermediate signal intensity. Now, remember this word, intermediate signal intensity. Usually, this is, malignancies will have this signal intensity. And this thing is sitting on the sigmoid colon. And here you are. All of this is metastasis, actually. Let me show you a sagittal which will make everything clear. This is the rectum. And you can see that this is the rectosignal. And this is a classical image for you, where you can see that there is a mass here sitting here. It is intermediate in signal intensity. If you look carefully, look at the lumen inside, and look at this wall. This wall is different as compared to the other wall, and you can understand that this metastasis has actually gone inside. So this is how it will produce. Look at this metastasis, and look at this lumen, and how it is adherent, and how it will produce fibrosis, etc. And on this coronal also, similar finding can be seen here. So I'll come out of this. And go back to my okay, candidate 3.
Yes, doctor.
Excuse me, because of time factor, I'm going to ask you a leading question. This patient is a 32-year-old female, pain and melena off and on. And do you see anything here?
Yeah, there is extrinsic, there is irregularity, single wall irregularity of the colon with spikes, and the rest of the colon is unremarkable. I think this is secondary to extrinsic compression or extrinsic lesion. Given the history of melena on and off in a female in the reproductive age, I'd consider possibility of endometriosis.
Excellent, well done. So I'm going to mute you, and well done, you have done very well. Now, candidate 4, be ready for. So I have unmuted you. Please stay with us, candidate 4. Now,
Okay.
this patient, endometriosis is an exam case. They can show you endometriosis on a barium, and there are various sites where it will adhere. Rectosigmoid is one of the classical sites, and just like what we have learned previously. On the other hand, it can be ileocecal also. So this is another example. Okay, candidate 4. This is your case. This patient has had a hysterectomy, and this patient is 34 years old. The patient presents with rectal bleeding. Over to you.
Okay. That's the multiple sagittal imaging T2 images in which I can see there is low signal in the upper wall of the bladder, superior wall of the bladder.
Good, you have picked this up. Good. Anything else?
And the rest I can see there is a previous hysterectomy. I want to look for that. And I can see there is a narrowing of the rectum as well.
Okay, let me tell you. Let me ask you. This is the rectum.
Yes.
So, and then we are coming to the rectosigmoid. What is this?
That could be a deposit or
Which kind of deposit?
Metastasis.
Look at the signal of this.
The slow signal on T2. So it. That's the 34 female. So it could be endometriotic deposit.
Excellent. You see, this is a classical exam film. What happens in endometriosis that this is hemosiderine, and hemosiderine is low in signal intensity on T2 weighted sequence. The deposits can be at the rectosigmoid. In this case, the deposits are on the serosal surface of the bladder also. And you can well imagine that this patient, she can have hematuria, particularly at the time of menstruation. She can have also melena. Key point to remember is that hemosiderine is low in signal intensity on T2. When we will do gynae MRs, endometriosis, endometriomas, all of these are exam cases. And there is a hysterectomy. So the patient might have had adenomyosis, and because of that, there is a hysterectomy. So it becomes a sort of a story film. Now, this case, if you look carefully on a barium examination, again, there was a bit of indentation. And final point is, signal intensity wise, remember these terms. Low signal on a T2 is like this low signal, and this is hemosiderine. Intermediate signal is this one is ovarian carcinoma. Usually malignancies will be intermediate signal. CS cervix, for example, will have a similar signal. So you have to develop your eyes on this signal and this signal. Okay, candidate 4. I'll ask you leading question.
Yes.
Look at the stomach, and are you happy? Everything is normal.
No. I think so. It's a intramural thickening.
Okay, you are worried about this thickening. That is fine. My question is now, thickening on a CT scan becomes a controversial subject because how much is the distension, etc. But your answer is fine. But I'm not interested there. Can you tell me what is happening here? What is happening here? What is happening here? What is happening here? What is happening here?
Okay, so I think so. It's a pyloric narrowing.
Is this the pylorus? You see, this is the adrenal gland here. You see this thing?
Yes.
What is next to the adrenal gland here?
Antrum.
So what is happening here?
I think so. And if I can see there is a air bubble in it, so
Very good, very good.
the fistula, any perforation or fistula?
No.
Formation?
Okay, okay. That's fine. I'll take over. You know, the eye see what the mind knows. The
Yes.
same thing, if I show you a bit of a close-up, you can see something is happening here. And then there is a bit of fluid, there is a bubble, as you have pointed out, and then this is adrenal. Okay, let me ask you a question. What will you do to confirm the diagnosis? You don't know the diagnosis, but what comes to your mind? You are doing a
MRI or endoscopic ultrasound. Oh no.
something more simple.
Positioning or barium.
Barium. So this is a barium examination, and what is your diagnosis?
So that's the ulcer. Diverticular.
Diverticula. Fine. Okay, well done. So diverticulae of the stomach. Please remember, most common diverticulae are from the fundus, but there is another diverticulum. The second most common site is close to the lower curvature posteriorly, and classically it will extend posteriorly where the adrenal sits. Many a times you can be confused because it will be abutting the adrenal. It all depends if there is fluid inside. Sometimes there will be no fluid inside. Even contrast might not be there. So beware of this. This is a known pitfall of a diverticulum. Barium can tell you when the contrast goes in, and you have to do a technique where you make it dependent. So left adrenal nodule, beware of confusing it with a diverticulum of the stomach. This is a more classical, most common diverticulum. Where is it candidate for?
It's in the tube.
First of all, tell me that what kind of a film is this? This is a barium meal examination.
That's the barium meal examination.
So what is the position of this patient when this film was taken?
I think so. Prone. That's supine. Or no.
So when there is air in the fundus, means
then it's erected. Sorry.
Okay, erect position, and in this position, what is your finding? Where is?
So in the fundal area.
Right. So here in the fundus, you can see this diverticulum, and this is the most common site of diverticulum. So this is another example of that kind of a diverticulum which is arising from the lesser curvature. It will go posteriorly, and this is the most common, which is the fundal type of diverticulum. Okay, candidate 4. This is a barium meal examination. What is your finding?
Okay, so that's the barium meal follow through, in which I can see there is a. I can see the pylorus is rotated downwards. So, I will correlate with the history and and I can see also there is a narrowing of the second part of the duodenum as well.
I'm not at all worried about this. This is simply not distended in this film. What is happening here?
That's the pooling of the contrast in the stomach.
Is it normal? Is the shape normal? What is happening?
The shape is not normal. I will correlate with the history of acute progression. Then it could be an organoaxial gastric volvulus.
So why do you say if it will correlate with an acute history? It can be an incidental finding. Okay, I'll take over. Basically, your diagnosis is correct. But having said that, now I am showing you volvulus of the stomach, which again is an exam case. But please remember the concept. There are two types of volvulus. One is known as organoaxial, and the second one is known as mesenteroaxial. The organoaxial is much more common than mesenteroaxial, but both of them can present usually asymptomatic. So this is usually seen incidentally, and this is very important to remember. And if the volvulus is more than 180 degrees, then the patient will present with obstruction. Similarly, mesenteroaxial can also present at times incidental, but more commonly it can present with obstruction. And mesenteroaxial is more common in children. Both of these volvulus can be associated with or without hiatus hernia. So in organoaxial, the stomach twists. If this is the long axis, then the main take-home point is that it twists around the long axis. And the take-home point is that the greater curvature sits upwards. So if you see this case, this is the greater curvature. So greater curvature is superior and the lesser curvature becomes inferior. This is the classical configuration. In a mesenteroaxial, on the other hand, it is around the short axis. So it will twist and then the antrum will sit, superiorly. So this is mesenteroaxial. Look at this, where you can see this is the esophagus. The gastroesophageal junction comes here, and then part of the stomach is sitting upstairs, up in the thorax. So there has to be a hiatus hernia, and it is a paraesophageal hernia, and this one is mesenteroaxial. So just to sum up, this one is a good example of organoaxial, which is not associated with a hiatus hernia. So remember that. On the other hand, this one is mesenteroaxial, where the pylorus is sitting up there, and then is the duodenum. I also warn you that when you are in the exam and the examiner might show you these volvulus on an axial CT scan, and you might be absolutely taken aback what's happening. So keep thinking and stretch your imagination, and it becomes very simple. The only thing is that the eyes do not, if you have not seen a particular entity on a particular modality, you at times find it very difficult to piece it together. So this is an axial of a volvulus, and this is the corona. So just wanted to warn you that on a CT scan, the same thing becomes a bit difficult. Now, the classical exam film, which might come in your exam, is the example here from StatDX, where this is a volvulus. So you pick up a volvulus, and you are very happy that you have picked it up, but the examiner is still not satisfied. Key thing here is to pick up, these foci of air. And these foci of air are intramural air. And candidate 4, what does it mean? What is happening?
There's air in the wall, so impending rupture or perforation, pneumatosis intestinalis.
Right. So this is means that the volvulus has strangulated and there is ischemia. So means there must be a twist of more than 180 degree. And now it is, impending perforation, or there might be a bit of perforation because there are some bubbles which are sitting outside. Next is candidate 5, and after candidate 5, I will ask candidate 9. So after 5, 9 should be ready. Thank you, candidate 4. Candidate 5, if you can raise your hand, please. And candidate 9, be ready. Candidate 5, you are with us?
Yes.
Over to you.
I'm presented with spot films from a double contrast upper GI barium study. There is an abnormality of the gastric mucosa of the region of the pyloric antrum, which is included, where the normal gastric folds are not evident, and the mucosa appears irregular.
So what is happening here? I am interested in this region.
Yeah, so within the generally irregular mucosa, there are small areas where there's punctate pooling of the contrast with a surrounding less dense area. They're multiple and they're small in size. They look like ulcers and they have the characteristics of aphthous ulcers.
What is your differential?
So it's possible that they are ulcers from another etiology, such as inflammatory or malignant, but I'd expect them to be larger in size and less multiple.
So what is your top differential?
So my number one differential is aphthous ulceration in the context of inflammatory bowel disease.
Okay, fine. So I've already pointed out that whenever there is, infection or inflammation, you might have in the submucosa, you might have fluid attenuation. So this is a sort of a repetition. But coming back to the aphthoid ulcers can be seen in, let's say, gastritis. And this is endoscopy. You can see similar. What happens is that there is a ulcer, is a depression. Around that is edema of the mucosa. So similar thing projects here on a barium examination. In a dependent portion, the barium pools and the edematous mucosa surrounded gives you this low density. So this is aphthoid ulcer. Now, aphthoid ulcer, this differential diagnosis, I believe, has been taken out from the present Chapman, because this is usually seen on barium examinations and it is not seen on other examinations like CT, etc. So you might not see it. But having said that, for me, it's still an important differential diagnosis for your exam. So this is from your old Chapman, and I want to warn you, in the Chapman, it is not mentioned that it can be seen in stomach. It is not mentioned it can be seen in esophagus. So I want you to remember like this. It is by definition a deep ulcer. It is an intramural deep ulcer, and Crohn's disease is the most common cause. So Crohn's disease can happen anywhere from the oral cavity till the anal canal. So in colon, in small bowel, in stomach, in esophagus. Other than that, if you see, other like non-steroidal, anti-inflammatory, etc., can also cause it within the stomach. Now, I want you to teach you, there are two differentials which again are not in your current Chapman, but they are important for barium examinations. And there was a lot of confusion about these two. One is ephthoid ulcer and second one is target lesion. Target lesion in the stomach is a very important differential, and it will be seen on a barium examination. So if you see here, ephthoid ulcer is the ulcer crater and the surrounding edema. Basically, target lesion is something like this. There is a mound and there is a crater. I remember it like this, that simple to remember is that target lesion is a bigger volcano and ephthoid ulcer is a very small one. So this is a ephthoid ulcer which you have already done. Look at this. This is a larger lesion. You can see that the crater, like this crater, is very large. Barium will go in and surrounding edema will be there. And you will see, it might not be as numerous as this example. So and there is a differential diagnosis in your book. Again, this is the 6th edition. And here, please add GIST also. And I warn you that target lesion is an exam case. So I will tackle it because I have already told you, look at this. This is a classical target lesion where barium is sitting inside, and look at this, edema or the mound, which correlates with this thing. So, and the differential here is, most common target lesion differential is actually metastasis, but there are others here also. And this is a case of GIST where you can see a target lesion. This is a very good example. Over to candidate 5.
So I'm presented with a spot fluoroscopic image from an upper GI barium study. There is gross abnormality of the stomach, specifically the body and pyloric antral regions, with multiple areas in which there are pooling of barium with surrounding less dense halo suggestive of cratering or mucosal edema. I can see 3 such areas along the greater curvature.
Excellent, excellent. What do you think overall? Are you happy with this appearance of the stomach?
No, so the mucosa is grossly abnormal and the stomach does not distend as much as I would expect for this amount of contrast administration. So I think that there is evidence of generalized luminal infiltration with large target lesions. My number 1 differential is lymphoma, but other malignant infiltrations would be included.
Right, very good. So the point is that this is, there is loss of distensibility of the stomach. One of the exam tips in barium examination, and this is a key tip to remember, whenever you find something, particularly loss of distensibility, you have to tell the examiner that in my usual practice, I would like to confirm it on a subsequent film, because there can be technical reasons for under distensibility. If the examiner wants to show you, will show you, otherwise they will say, okay, fine, this was, persistent finding. So you have to, always ask for, is it a persistent finding or not? What is happening here, that there is loss of distensibility, and look at the mucosa. Mucosa is abnormal. This is a linitis type of picture. With that, 1 target lesion, 2nd target lesion, and in a profile, 3rd target lesion. And the differential will be metastasis. For example, please remember that this is, linitis. There are many causes of linitis, The most common is gastric carcinoma. But lymphoma and metastasis, particularly metastasis from breast, can also cause linitis. So this patient had both of the entities. Last film for you, and then we will take a 5-minute break. What do you think about the stomach? Over to you.
These are selected axial cuts from a contrast-enhanced CT of the abdomen, and there's one with lung windows. There seems to be gastric wall thickening with increased attenuation consistent with enhancement in the region of the mucosal side of the surface, surrounding some fluid that's within the stomach. For example, in the upper right image.
What's happening here?
So there's low density fluid within the stomach lumen, and in that particular section, there appears to be a discontinuity of the stomach wall.
Excellent.
And in that context, we can see free intraperitoneal gas and a small quantity of free intraperitoneal fluid. The overall appearances are of gastric perforation secondary to ulceration, which could be inflammatory or neoplastic in nature.
Right. So if you look carefully, if you see this antrum, candidate 5, you can mute yourself. After the break, it will be candidate 9. So be ready, candidate 9. So if you see here, you can see whole of this stomach is a bit thickened. This is the antrum. I do acknowledge that, this is because it's not completely distended. But having said that, here, definitely there is antral thickening. And if you see the continuity here, there is discontinuity. This was a case of linitis, actually, with perforation. And so this is a classical case which can come in the exam. So we stop here. This is going to be a 5-minute break. And after the break, it will be candidate 9. So be mentally prepared. I am muting myself and switching off my video. Yes,
Yes.
this is a very difficult case, and unfortunately, it comes to your luck. Classical exam film, and over to you. Let me guide you because of time factor that this is a barium meal follow-through examination. Over to you, please.
Okay. The stomach looks slightly abnormal. There's irregularity of the lesser curvature and the greater curvature, with perhaps some areas of ulceration. The duodenal cap looks a little bit narrowed, but then the D2 and presumably D3 segment looks okay. The distal duodenum and the jejunal loops look, again, they look abnormal. They look slightly strictured, narrowed as well.
Excuse me, well done, but can I stop you because of time factor? I'll ask you a question.
Yeah.
What part of bowel is this?
To be honest, I'm not really sure. It could be another part of the small bowel. They look like they're communicating with the stomach, which would be concerning for a fistula.
Very good, well done. Please continue. Now, if you see here where I am pointing out, where are we here? Which part of bowel is this one?
That actually looks like a large bowel, so like a descending colon.
Okay, so can you conclude then what's happening here?
So there are skip lesions, strictures, and fistulas. My first diagnosis would be a Crohn's disease.
Are you happy with the appearance of the stomach itself?
No, I think the stomach looks abnormal. With irregularities and ulcerations, and perhaps under distension as well. So it could be a stomach malignancy on a background of Crohn's disease.
Okay, okay, fine, well done. This is a classical exam film where you have to ask yourself, is the contrast at the right location for the timing of that film? Now look here, what is happening? This stomach is totally abnormal. This is a linitis type of stomach. It has got, mucosal destruction here. The pitfall here is that there is a duodenal pulp. Actually, the contrast hasn't gone into rest of the duodenum. D2 is not there, D3 is not there. Actually, what happens? That from here, the contrast has gone into the transverse colon. And part of it, of course, has gone into the jejunum. I'll come back to this point. Please remember the anatomy. You remember gastrocolic ligament. So in a neglected case of carcinoma of the stomach, it can go through the gastrocolic ligament into the transverse colon. In this case, this is what has happened. And then there is a fistulous communication between the stomach and the transverse colon. And then contrast goes into the splenic flexure, goes into the sigmoid. On the other hand, there must be a fistula with a bit of jejunum also, either through the transverse colon or directly, because part of the contrast has gone into the jejunum. Now, what is happening? In the distal large bowel, small bowel, there is not enough contrast, and this is the ascending colon or the hepatic flexure where the contrast has gone. It does not go all the way around. So this is the type of film in which you have to stretch your imagination, should I say. Is the contrast at the right location or not? Okay. This case, I will give you the findings. Actually, let me tackle it as a teaching case. Here, what is happening, that there is an enhancing nodule here in the region of the pancreas. And with that, there is an enhancing nodule in the liver, and which shows washout. And if you see the stomach, the rugal folds of the stomach are thickened. So the idea here is to learn what is happening. Basically, when we will cover pancreatic tumors, we will cover a tumor which is gastrinoma. It is one of the neuroendocrine tumors of the pancreas, which is a very important exam case, and we will learn about them in the next session. But having said that, gastrinomas can also produce loss of ulceration, etc., and they can cause hyper enhancing metastasis in the liver. But my idea here was to teach you rugal thickening of the stomach. Now, rugal thickening of the stomach is a differential diagnosis which has been taken out from the current Chapman, but you can see it in the old previous Chapman, thick stomach folds, and there can be various causes about it. Causes, Zollinger Ellison is there, Menetriers, etc. There are causes. So first of all, what exactly are rugi? We know that these are oriented. These are basically mucosal folds, and submucosa is part of it, which are oriented parallel to the long axis of the stomach, and they present, best they present is on barium like this. So these are the rugal folds. This case is from literature of thickened rugal folds. But having said that, thickening of the rugal folds can also be seen on a CT scan. This paper here is slightly beyond your 2B level, so I don't want you to sort of confuse yourself. But having said that, those of you who are interested in GI radiology afterwards, you have to read papers like this. This is from AJNR, MDCT of giant gastric folds. Please remember that this is mucosa, this is submucosa, this is muscularis. And in a usual enhancement of the wall, you can see what we call stratification pattern. This is a arterial phase scan normal, where the mucosa is enhancing like this, submucosa like this, and muscularis like this. And this pattern is known as stratification. In tumors, etc., you lose that stratification. This I have already shown you an example. But rugi can also be seen as like this, thickened mucosal folds. And one of the description which is given in the book says, they're convolutions like gyri of the brain. So this is how the description is. So idea here was to teach you another differential diagnosis, and that was the differential diagnosis of rugal folds. So what I'm going to do is, this case which I have just shown you, I will show it to you again, and this time I will show you in a PACS format. And this is a very, very important case for your, long cases also. Now, candidate 9, can you see my screen as in PACS case pancreas 1? Candidate 9, are you with us?
Yes.
So can you see my screen, 60-year-old male?
Yes.
Okay, so I am going to, this is a teaching case, and I'm not going to ask you anything. This is the same case. But I want to tell you that these kinds of cases are very important for your long cases. Now, on this non-enhanced, you can see a bit of thickening of stomach. And on this arterial phase, you can see this enhancing liver lesion, and then you can see something here. If you see, This is the uncinate process of the pancreas, and you can see this enhancing nodule. And,
Yes.
and similarly, if you see on arterial phase, look at the stomach and look at the rugae, and they are all thickened. On this sagittal, you can see this enhancing nodule. And on portal venous phase, look at this, develop your eyes on this. You know, that brain gyriform type of appearance. And with that, you remember that lesion which was enhancing, it has shown washout. Please remember that a lesion in the liver which shows arterial phase enhancement and washout means malignant. So this is a gastrinoma causing and with hepatic metastasis and with Zollinger-Ellison because of the rugal fold thickness. So this is a very classical exam film. So we will come back to our original So candidate 9, are you with us?
Yes.
Okay, over to you. This is a very good film for the exam.
So this is a barium meal study. I think this has been taken in an oblique projection, possibly. There's pooling of contrast in the fundus, presumably fundus of the stomach. The orientation of the stomach is slightly abnormal, but this could be secondary to the oblique projection. The demarcation within the pooling of the contrast is slightly lobulated and irregular.
Look at the shape of the stomach. Normal, abnormal. You see, this is the stomach, and then you can see contrast in the jejunum.
It looks abnormal. It looks upside down, which makes me think of possibly volvulus.
So let me tell you, this is a classical exam case, a story film. The film tells you a story. That is the hint.
So the configuration of the stomach is abnormal. I can't identify the pylorus and the duodenal cap. There are of jejunum inferiorly, so I would correlate with any history of surgical procedures, in particular formation of gastrojejunostomies.
Gastrojejunostomy. Okay, fine. Let me take over because of the time factor.
Yep.
Now, if you see here, there is something else. This pooling here and pooling here. By the way, before I take over, can you stretch your imagination? What will be this thing? I can show you a profile image for this also. Here you are. They're going out.
These are small diverticules from the jejunum or pseudodiverticulum.
If you see here, this is the stomach, and this is the site of the gastrojejunostomy, and with that there are projecting ulcers. But the key thing here is the story. What is the story? The story is that this patient has had surgery, and this is a classical exam film. You see, what happens is, please remember that peptic ulcer disease was one of the major healthcare issues of the world till 1970s, 80s. And, there were so many patients who had surgeries, so common to have surgeries. Now, we have got medicines to control all of this. It has drastically changed. And if you see Tagamet and read the history of Tagamet, H2 blocker, etc. Sorry, I think beta blocker or something. Now, of course, the concepts have changed. This was the first drug which earned $1 billion for the company. Now, many patients who are still around have had surgeries around peptic ulcer disease. First thing is you have to understand what kind of surgeries can happen. First surgery is known as Billroth 1, partial gastrectomy, because they will remove the antrum and then produce a jejunostomy. So this is what you are looking. You are looking for antrectomy and with that jejunostomy. So this is a classical exam film where you have to tell the examiner what has happened. And this, on the other hand, over to candidate 9. Do you see the antrum here?
Yeah.
So is it normal or abnormal? You know the shape. I am asking you, the question is very specific. Gastric antrum, is it abnormal? So what is happening? So this is the duodenum. And GIT, it is again post-surgical.
The antrum looks a little bit smaller, perhaps reduced, I guess.
So which kind of surgery has been performed?
Antrectomy.
Excellent. And this is known as, if you see another view here, this is known as Billroth 1. Here what happens is that they remove the antrum, but anastomosis is between rest of the stomach and the duodenum. In the previous one, there was no anastomosis. It was a blind end. And this was Billroth 2 operation. This one is Billroth 1. In the example which I have shown you, candidate 9, what is this thing?
It's an outpouching from the duodenal cap.
So how will you complete the story?
There could be pooling of contrast secondary to an ulcer.
Excellent. So this is a giant recurrent ulcer, and this patient has got Billroth 1. So Billroth 2 and Billroth 1, both are exam cases, and if you know this appearance, only then you can pick it up. Okay, this is an excellent exam film. This is your last film, but it is a very, very good film. Over to you. Because of time factor, let me tell you that if you look carefully, the posture of this is slightly different than this. There is something here, and that something has moved now. Over to you. And there is a bit of surgery also.
Okay. There is surgical clips projected over the gastroesophageal junction. There is pulling of contrast in the first film on the left, which I think is an AP projection supine, predominantly in the gastric fundus. The configuration of the stomach looks slightly unusual. It's more rounded rather than conforming to the normal stomach shape. On the second projection, the large area with the pooling of the contrast has moved. I wonder if that's rotational because of patient positioning or secondary to an internal structure such as food material or bezora.
Excellent. Okay, I'll take over. Now, this is a very well done, and you can mute yourself now. Thank you. Next will be candidate 6. Be ready. Let me tell you about this film. Now, on this film, there is something here which has got this mottle type of an appearance. With that, there is antrectomy. So this is again Billroth 1. These surgical clips, in that era when they used to do these kinds of surgeries, they used to do what we call, partial or, selective vagotomy. So vagus nerve or its branches were also cut. So this is that evidence. With that, you can see this mass. This mass has got a mottle type of bubbly appearance. The key thing is it's mobile. It is moving inside. When you see this bizarre kind of an appearance, The only thing which comes to your mind is a bezoar. What is a bezoar? So bezoars can be various types. Phytobezoar is the most common, which is because of vegetable material. And there are trichobezoar, which are because of hair, usually young girls. They keep eating hair, and it is basically, bezoar is undigested food. You can have lactobezoar in babies, and latest is you can also have pharmacobezoar, as in undigested food material, medicines. So these are the types of bezoar. Always think bizarre, it's a bizarre appearance with mottled appearance, gives you a mass type. So keep your minds open about it. Candidate 6. This patient has had bariatric surgery. What has happened here? Is everything in place or not? Over to you.
Okay, so these are selected spot films from a barium study. There's evidence of a previous gastric band. It appears that the gastric band may have slipped inferiorly, with a larger portion of the gastric fundus seen above it. I'd expect the gastric band to be pointed more sort of superiorly towards 1 to 2 o'clock, but on the second image we can see that it's pointing more inferiorly.
Excellent, well done. So let me explain to you now. Bariatric surgery is, please remember, I think 2 or 3 years ago, I don't remember, it is now even offered by NHS. But bariatric surgery, there is a lot of stuff going on. So the film, which, there are so many complications, so many things, and usually this is beyond 2B level, should I say. So I'm not going to teach you anything other than this one complication, which is a potential exam complication. And please remember, you can also see it on a CT scan. And I've seen quite a few patients now. Now, what happens in a gastric band procedure? So first of all, gastric band has got various components, which can be seen on this diagram. They produce a small stomach. This is the stomach. And this stomach has got a capacity of only 30 ml or so. And this is connected with a port which goes into the thoracic wall. And so we can put in fluid and reduce the amount of fluid to tighten it or untighten it, etc. There are so many complications which can happen. But the exam complication is this one. Look at the axis or the lie of this. This is at about 8 o'clock to 2 o'clock, or 7 o'clock to 1 o'clock position. It should not slip down. That is known as slippage of gastric band. If it slips down, then what will happen? So look at the orientation, and please remember, they will show you on a plain film. If this orientation changes, you have to call it. I'll show you another example. So this is just to orient the gastric band, and this is the new stomach. And look at this. This is the classical exam film from StatDX, which you are expecting. Look at the band and look at the orientation, and you will agree 4 o'clock to maybe 9, 9.5, or 10 o'clock position. It should have been somewhere here. And when you do gastrographin or whatever, you can see that there is obstruction. So slippage of gastric band is important as far as bariatrics is concerned. Okay, candidate 6. This is a single contrast barium examination. Anything you can pick up in the stomach?
So I can't make out any of the rugal folds, but it's all contrast opacified. In the region of the fundus, there looks like there might be a rounded filling defect.
Excellent. So this is the CT scan of that. What is your differential? This is for differential, nothing more than that.
So it's a gastric mass. The differentials could be either benign or malignant neoplasms. Perhaps on the malignant side, it could be a sort of polypoid shaped carcinoma or a GIST.
Okay, very good. So just to, we are doing now another differential diagnosis, and that differential diagnosis is a mass within the stomach. So gastric masses or filling defect, and this is a huge list. GIST is a very important tumor for your exam or for your real world also, because stomach is the most common site of GIST, intestinal stromal tumor. GIST can be benign and they can be malignant. You know, by definition, not a definition, but general concept is that anything more than 5 centimeter, you should be worried about malignancy. GIST, and the classical exam case is this one. Over to you, candidate 6. So, axial, what do you think is happening?
So there's irregular thickening of the gastric wall.
So do you think that this is gastric wall is irregularly thickened where I am pointing out?
Yes.
Okay. What is this? And what is this?
Oh, so the more medial structure is the stomach.
Excellent. So what is this?
So that looks like could be a collection, a large.
Okay.
Pancreatic.
So, okay, hint. It is in the same differential which you just did. That's the hint.
So it's so the fluid level. Sorry, I was going to say the
GIST.
It could be with a cystic component to it.
Okay, well done. So if you know GIST, you have to remember that GIST can be exophytic and they will sort of grow outwards. And if you don't know it, you will always be confused. And this is a very, very good film, very good case. If you see here, this is the stomach lumen. And what happens is exophytic GIST, usually GIST, the central part of GIST can cause, can necrose. And then it will communicate with the lumen. And you can see these air fluid levels and things like that. So this is an exophytic GIST. And you can see here, this is the stomach and this is it. Look at the size and you can define it that this has to be, you know, potentially malignant. This is the spleen and look at the wall which is here. Actually, unfortunately, this patient, when after about 2 weeks of this CT, a surgery was being planned, but just before the surgery, a few days before, this just burst open and the patient died. So this is an exophytic GIST. Now, this is your last film, and rather this is your second last film. Now, this patient is from A&E trauma. You are the on-call radiologist, and this, you can see lacerations of the liver, but what is happening around the duodenum?
So on the selected axial images that we have and coronal sequences, we can see that there's multiple small locules of gas around the duodenum. In the context of this trauma, I'd be suspicious for a laceration of the duodenum.
Right, very good. On a Cyrex, of course, you are handicapped here, but on a Cyrex, you will pick it up. Please remember that duodenum is a retroperitoneal structure, and part of the idea was to show you that part of the gas is going around the kidney also. And you can see that this is the wall, this is the wall. Actually, in this particular case, you can see the, the defect in the duodenum. So this is a duodenal perforation. Now, the idea was that the patient might have some other finding and will present as a case of trauma, but you should keep your minds open to look for more and more findings. So duodenal perforation was there. This is your last case. This patient is a 21-year-old female, one day after road traffic accident, and so a gastrographin meal and follow-through was done. What is happening here? Over to you.
Okay, so in the second and third part of the duodenum, there appears to be a narrowing of the lumen, where we can see only a faint line of contrast passing from the proximal duodenum into the jejunum.
How do you explain this finding? Let me show you a CT scan of the same patient.
So there's a low density lesion around that part of the duodenum. It could be a hematoma that's compressing the duodenum.
And where is this hematoma located?
On the fourth axial image, it looks like it's within the wall of the duodenum.
Excellent. So you basically intramural, we call it intramural hematomas, and intramural hematomas can happen in the duodenum, and that is the take-home point. You see duodenal wall folds and thickening or mass, vascular intramural hematoma. It becomes an exam case. If you know it, you will pick it up, otherwise you will not. And you see that it is not causing a significant obstruction, and contrast has gone distally. Thank you, number 6, well done. And we are going to number 7. If number 7 is with us, raise your hand. Okay, now, can you hear me, candidate 7, please?
Yes, sir.
Okay, if you see here, because of time factor, I am going to tell you that this is a non-enhanced phase. This is an arterial and slightly delayed. Over to you, what's happening? Acute abdomen with hematemesis.
Sir, I can appreciate a fluid density linear structure in the central abdomen, interior to the abdominal aorta. There is, in the post-contrast images, I can see that there is some a few areas of contrast as well. And this area seems to communicate with the bowel in the upper 2 rows. So it is likely a bowel like structure with disrupted peripheral contrast areas.
So you're using the, excuse me, you're using the word bowel. Can you tell me which part of bowel it is?
So it is likely duodenum. It is likely duodenum. Okay. Yes, sir.
Fine. Okay, so this is a classical case of leaking, or bleeding ulcer in the duodenum, where you can see on the non-enhanced, you can see this high density, then you can see this blush of contrast means that there is active bleeding. This is a classical exam case, and in this kind of a case, then they will go into interventional radiology. What can you do and things like that, embolization, etc. Okay, this question has been asked in the exam. What I have written here is from the previous Chapman, and that this has been asked that what is capability of technetium labeled RBC versus MDCT versus DSA of picking up bleeds. So this is why I mentioned it here. It's a sort of a viva question. Another similar film, because of time factor, I will like to tackle it myself. Aortoduodenal fistula. This is a very important exam case. Aortoduodenal. Previous one was a spontaneously bleeding ulcer, so that was different, right? GI bleed. This is different. Here, there will be a story. The story will be that the patient might have had some grafting of the aorta as an aneurysm, and then has developed infection. So there might be stigmata of infection. And with that, there might be stigmata of active bleed. So this is a case from Radiopedia, where you can see this high density within the lumen. So this is the duodenum, which is high density. And on early arterial phase, there is a bit of blush inside. And then on delayed phase, there is more active bleed. And this is the type of case in which you will see that around the graph, there might be signs of infection, etc., a few air bubbles, etc. So this type of case has come in the exam quite a few times. So that's why I was trying to show it to you. This is the last case of the chapter, and over to you. We know that there is a projecting ulcer here. So I know it. I am not worried about it. This patient, the history is that this patient, after eating meals, has got a lot of distension and at times vomiting, cannot retain the food. What are the findings on this single study? A single view, should I say?
So there is some narrowing in the third part of the duodenum, and which seems to be from some extensive compression, because this is circumferential narrowing at this particular position. And the rest of the mucosa of the second part of the duodenum appears to be normal. There is distal passage of contrast seen in the distal part of the duodenum, so which means that there is partial narrowing or partial obstruction, and there is a filling defect or a hypodense area overlying the narrowing. So it, as this patient is a known peptic ulcer disease patient, and so it might be a lesion which is causing the transient compression of this particular
candidate 7. If you see here this compression you are talking about, let me give you a hint. Look at the mucosal pattern. It is absolutely normal. Number 2, there is a sort of a band-like filling defect here. Part of the contrast goes distally. There is a bit of transient dilatation also. So with this, what comes to your mind?
Webs. Okay. No, I'm not sure that if there is.
Go to anatomy. Okay. And go to vascular anatomy. Here.
Sir, compression syndrome, sir, show superior mesenteric vessels show compression.
Excellent. Syndrome. Okay. Well done. Well done. You can mute yourself. Now, if you see here superior mesenteric artery syndrome, what happens in superior mesenteric artery? Basically, if I show you this CT scan, This is the abdominal aorta, and this is the SMA, and the third part of the duodenum, it passes through it. Now, sometimes, for example, if there is no retroperitoneal fat, then what will happen that this SMA, this because the distance between the SMA and the aorta will decrease, it will have a nutcracker type of a effect here. So you will get a band-like opacity here. If you do fluoroscopy, this is what I'm telling you is a exam type of a answer. On fluoroscopy, what happens is we call it to and fro sign. If you do a fluoroscopy, you will see that contrast peristalsis will come here, it will go back, there will be a bit of dilatation, it will come here, it will go back, and ultimately it will pass through. On fluoroscopy, we have got a good sign, and to and fro movement will be there. On a single film, this is what you are going to get. And so a classical band-like structure here. This, by the way, is a diverticulum. You already know this. So this is known as SMS syndrome. SMS syndrome also can be very symptomatic. Please remember that. And CT has got some other criteria. So on CT, what we do is there is a bit of literature, but what I have written here is take-home points. On an axial, if this is the SMA and this is the aorta, the distance between the outer walls of SMA and aorta should not be less than 8 millimeter. There's a bit of discrepancy in literature, but I think this is a cutoff point. Anything less than 8, you can call it. Secondly, go for a sagittal. And if you see, this is the SMA. Usually, there is an angle between SMA and aorta. If you draw a line like this, another line like this, and measure this angle. And the take-home point is that if the aorto-mesenteric angle is less than 22, you call it. Again, a 5-minute break. Candidate 7, thank you. Sorry, you just got 2 cases, but because of time factor, we have to rush. You did well. And after the break, it will be candidate 8. Okay, candidate 8, can you hear me?
Yes, I can.
Okay, the screen is projecting for you, small bowel studies.
Yes.
Okay, so I will tackle this and then I'll ask you a thing. Now, for small bowel, we have got various kinds of examinations which we can prove, and you people should know what are these. And we can, in the barium world, we can do a barium meal follow through. A barium meal follow through is simple, where we just give oral barium and follow it through the small bowel. Then we can do a small bowel enterocolysis, also previously known as small bowel enema, where we put in a tube into the proximal duodenum. Then we give double contrast, we use methyl cellulose, and it gives a lot of distension of the small bowel. It's a very good study. But the patients, of course, they don't like it. Nobody likes a NG tube going in and to then manipulate it into the proximal duodenum. Then we have got a CT enterography, simple, where we use oral contrast and then we do a CT in a portal venous phase. We can also do a CT enterocolysis. Very few people are doing it, where we put in a contrast, a tube, just like small bowel enterocolysis. And then on MR also similar techniques can be done. MRE I am going to teach you because MRE is now very important for the exam. But MR enterocolysis, very few people are doing. Again, same technique. So these words should be in your vocabulary. Now, as far as jejunum is concerned, please remember the difference between jejunum and ileum. We know that there are vulvally conventives in the jejunum, and the number of vulvally conventives in the jejunum is much more than in the ileum. And this is important for you to remember for your exam. And a few films will come in the exam around this concept. Also remember the concept of mesenteric border as well as anti-mesenteric border. So mesenteric border is, of course, to the side of the mesentery, and the other one is anti-mesenteric border. Most of the pathologies, they happen at the mesenteric border. Anti-mesenteric border, remember Meckel's diverticula. That is important for the exam, anti-mesenteric border. And otherwise, pseudosaculations of, let's say, scleroderma, they happen on the anti-mesenteric border, or at times pseudosaculations of Crohn's disease, they also happen at the anti-mesenteric border. So I will show you these concepts, but always remember Meckel's diverticula. This is a barium meal follow through. You can see that normal feathery pattern of the jejunum, and as we go distally, you can see that there is paucity of the vulvally conventives. Now, this is small bowel enterocolysis. No investigation shows the mucosal pattern of the small bowel as well as a small bowel enterocolysis. They can show you in the exam. I don't think so. Very few people are doing it now, and very few people have the skills to do it. Basically, methyl cellulose is used with buscopan, etc., to give this coating. But small bowel enterocolysis is very good to teach you anatomy and some findings. So if you just concentrate on this concept, and this concept is a very important exam concept, that on this spot film of small bowel enterocolysis, you can see that these are the jejunal folds. Now, this black thing here is the vulvally conventi, and this is the space in between. If I show you this diagram, so this is that vulvally conventi, And this thing here is the space where the barium is. So this is known as interspace, right? So this is the mucosal fold. This black thing is the thickness of the mucosal fold. So number one, see how many mucosal folds are here. It is written per inches, and there are 4 to 7 per inch. 1, 2, 3, 4. 4 to 7 per inch. But in ileum, these are 2 to 4. Second thing is, look at the thickness of the fold, and you will agree that this is more thick as compared to this one, 2.5 versus 2 millimeter. So this concept is important. Candidate 8, classical exam film. Because of time factor, I'm going to ask you leading questions. This is a small bowel enterocolysis. Contrast is, so there is a catheter in the duodenum. And what is your finding?
So I'm presented with a spot film of small bowel enterocolysis with a catheter seen in situ. This, as you told, is in the jejunum. The striking abnormality that I can see is that the jejunal folds are not what we expect to see. So there seem to be less valvular conjunctivitis.
Excellent.
Yes, so that means that the folds are less.
And
that should be expected
what
in the
comes to your
jejunum.
mind here?
So so the top thing that comes to my mind would be that this is reversal of the fold pattern which occurs in celiac disease.
Excellent. So in celiac disease, what happens is that there is atrophy of the villi, and then there is what we call jejunization of ileum. And this film is a favorite film for the exam. Even this is a second case in which, look at the proximal fold, there is no, though it's single contrast, but more distally there is so much. Here, distally there was much, and here there was no fold. Do you think this is malignant or benign? Candidate 8.
The stricture appears to be short segment and irregular, with some shouldering as well. And if the patient is a known celiac disease, I would kind of suspect it to be malignant as well, until and unless ruled out, because it has more association with lymphoma or carcinomas of the bowel.
Excellent. So celiac disease also is, it is associated with lymphoma as well as carcinoma. This is a classical malignant stricture where there is apple core appearance, overhanging edges, etc. Okay, this is a case of Crohn's disease. First of all, this is the terminal ileum. But what is this where I am pointing out? This thing.
Is this like a spot magnification kind of thing?
Okay, so this is a classical exam question. They will show you terminal ileum film with a compression device, and this is that compression device. And this device is needed so that the loops do not overlap the ileocecal junction. Now, with that background, this is a case of Crohn's disease. You tell me, why is it Crohn's disease?
Okay, so on this spot film with magnification view of the terminal ileum and ileocecal region and some part of the large bowel as well, I can see stricturing in the area of terminal ileum with some luminal narrowing, and possibly some aphthous ulcers in between where there is less filling of the contrast.
Okay.
There is further stricturing which I could see in the part of the large bowel that is seen. Could be could be in the transverse colon, yeah.
No,
like
this
just
is
above
another
it.
loop of small bowel.
Okay, okay. So, all right. So if that is a loop of small bowel, still I can see some narrowing and stricturing in that part as well. So if that's a stricture as well, that would represent a skip lesion.
Okay, well done. So now Crohn's disease, please remember that one Crohn's disease can happen anywhere from oral cavity till the anal canal, number one. Number two, Crohn's disease inflammation is transmural. So it goes through its deep ulcers, which you will see, and means it can penetrate through the serosa, and that is why there can be so many fistulas. The fistulas can be because in between bowel loops. It can also be a cutaneous fistula and things like that. So, and when we will cover ulcerative colitis, there you will understand that ulcerative colitis is only superficial ulceration. Now, skip lesions is another thing which is quite pathognomic for Crohn's disease. So, skip lesions means that there will be areas which are normal. Now, what is happening here is that there is a stricture which looks like sort of a close to a fibrotic stricture and very smooth. This is the mesenteric border. This is the anti-mesenteric border. We call it pseudo-sacculations, which can happen, fibrosis which happens on the anti-mesenteric border. You can see this stricture here. And then there is a skip lesion, and you can see these aphthoid ulcers. Aphthoid ulcers, wherever you see them, and they have come in the exam again and again, small bowel, large bowel, whatever, Crohn's disease should be up there. And aphthoid ulcers, by definition, are deep ulcers. Remember that. So in ulcerative colitis in large bowel, you will not see them. So this is the differential of aphthoid ulcer. This is the differential of ileocecal region thickening. Please remember that ileocecal region abnormalities. So I am basically from Pakistan, and in Pakistan, or let's say in India or subcontinent, if you see anything in the ileocecal region, you call it TB, because TB is so common there. And I remember back home, we never used to call it Crohn's disease, and it's vice versa in UK. So remember that here it's vice versa. It's Crohn's disease, Crohn's disease, Crohn's disease, unless proved otherwise. That does not mean that you should not include in your differential. So you should know a few discriminators between TB and Crohn's disease, and we know that more involvement of the cecum is one of the discriminator. It can mimic, by the way. That's number one point to remember. But otherwise, necrotic nodes, more fistula, things like that. You might get with this a TB. You might get X-ray film as a long case and things like that. So TB of ileocecal TB in UK is rare. Crohn's disease is very common. Having said that, you have to keep both of them in your differential. Now, I am going to teach you something here, which will help you to pick up an exam finding. In Crohn's disease, what happens is that ulcers are deep ulcers. And some of these ulcers can be very linear. Look at this ulcer. Actually, this is an ulcer, and the mucosal folds are radiating towards it. It's a deep ulcer. It's knife, just like a knife edge or things, stab type of a ulcer. With that comes this classical exam finding. Yes, candidate 8. How will you describe this? This is a classical exam finding.
So I'm presented with spot films of barium enema or follow through, which I cannot make out on these images. So there is abnormality seen involving the bowel loop, which appears to have thickened folds, irregular mucosal irregularity, and multiple outpouchings outside the lumen, which may represent multiple aphthous ulcers.
What do you call this appearance?
So this appearance is called edematous mounds of tissue. So this is called cobblestone appearance.
Right. Okay. So thank you, candidate 8, and next is candidate 10. Now, this is, first of all, if you see, I showed you one ulcer, which was what we call a linear ulcer. Now, look here, what is happening. There are so many ulcers. This is one ulcer, second ulcer, third ulcer, and with that there is edematous, mucosa, gives you this cobblestone appearance. If you see these in profile, look at this. This is that rose thorn type of an appearance. Look at all of these which are in the profile, which are projecting outside. What does it tell you? They are going into the wall. So this is intramural, and these are deep ulcers. So this is Crohn's disease. Okay, candidate 10, over to you. Classical exam film.
Okay, so this is a spot image in the pelvis, in a 40-year-old female. There are filling defects in the region of the terminal ileum, extending into the cecum. There appears to be a sort of contrast extending from the small bowel loops into the what looks like the bladder, the urinary bladder. This could be in keeping with a fistula.
Okay, very good. What's happening in this region? This is the ileocecal junction.
So this is not much contrast or pacification. It could be suggestive of ulceration or strictures in the terminal ileum.
So if this is the terminal ileum where I am pointing out, there is a stricture there, then what is this? And what is this? And what is this? So first of all, what is this?
Terminal ileum?
Basically, what I'm asking is, there is a connection. So this is the terminal ileum. I'll take over this. This is the terminal ileum, and this terminal ileum has got a stricture. And then there might be a bit of obstruction because there are upstream dilatation. With that, there is a connection between this loop and this cecum, and this is a ileocolic fistula. Another ileocolic fistula is this one. And then there is an ileal fistula here. You have picked up this very well, where you picked up that there is a contrast in the urinary bladder where it should not have been any contrast, and then you can see a faint outline there. Please remember, in the exam they will show you contrast in the bladder without any fistula, but you can infer that there must be a fistula. So this is a case. So I'll show you various examples of fistulas and on various modalities, because they are classical for your exams. So I want to develop your eyes, and I'll show them on barium and CT and MR. So we know that this is Crohn's disease. What is your finding, candidate 10?
So the multiple fistulas extending from the distal sigmoid colon to the terminal ileum, in keeping with
right. So it's, if you basic pathology is here in the ileum, and there is a chronic type of fistula, and then there are two connections. So ileocolic fistula. So the basic pathology is in the ileum. Okay. Again, similar to previous, just tell me the fistulae. In what and what?
Between sigmoid and terminal ileum, so ileocolic.
Okay. Now, one thing is that in the Viva, they can ask you that what kind of a film is this, and if you go to barium enemas, to outline the rectum, we do a 35-degree angulated film, and this is that film. Number two, sometimes we do prone films, and this is a known pitfall in the exam. They can show you follow-throughs, they can show you enemas where your anatomy changes and the cecum might be sitting on the other side. So beware of this, that it might be a prone film. And so there is a stricture here, and then there are strictures and fistulae formation. Okay, spot film, candidate 10. What is abnormal on this? Barium
So
will follow through, but what is abnormal?
there's contrast in the urinary bladder.
Excellent. So that means there is a fistula there. Okay, I am going to show you a CT scan, and this is a brilliant film of a CT because so many films now come in the exam where once you know the same pathologies, the same pathologies where you can see on a barium, you can see on a CT scan and things like that. So candidate 10, can you see the CT PACS case 3 written on your screen?
Yes.
Okay, so I will tackle it, and it's a sort of a, sorry, I have shared a wrong screen with you. So can you see these CT images?
Yes.
Okay, all of you please concentrate, and this is the type of film or a case which will come in your long cases also. So this is an incidental finding, I'm not worried about that. Now, if you see, look at this loop, and this loop has got a bit of a, we call it small bowel feces sign, where there is some material within the small bowel. You can see a bit of thickening, and then you can see this acutely inflamed loop of ileum, and you can see this Coombs sign. We call it the Coombs sign, where the vasa recta, they are enhancing. Fat around N, this is mesenteric fat, which is around this loop. They say that it is pathognomic for Crohn's disease. There is no differential diagnosis. Another thing which is visible. Now look at this loop, and how does this continue here? This is the ileocecal junction. But I am more interested in what is happening in the mesentery. So there is a, transmural, definitely abnormality where an abscess is sitting here. And this abscess is in the mesentery, a lot of fat standing. And then this is extending. Now, this is the sigmoid colon, and you can see it is abutting the sigmoid, just like, and you might, right now we cannot see it, but there might have been a fistulous communication. At least these two loops are adherent to each other. Then as I am proceeding further, you can see this abscess with rim enhancement. Where is it sitting? This is the urinary bladder. It is sitting on the posterior surface of the urinary bladder. Right now, it is not fistulating into the urinary bladder, but you can infer that, in a few days' time, it might, and then you will see air inside the urinary bladder also. I'm not interested in these ovarian cysts. These are incidental findings. Now, if you see this coronal, and again develop your eyes on this, lot of fat standing, and that Coombs sign, etc. And you can see this was that mesenteric abscess, and you can see how it is communicating. This is that abscess which is sitting on the urinary bladder, and this is the sigmoid colon. So and on a so this CT scan tells you that CT is quite a robust investigation to show you everything regarding Crohn's disease case and things like that. And many a times they will show you in the exam. Right. Let me close. Candidate 10, are you with us?
Yes.
Okay, now candidate 11, are you with us? Can you raise your hand? So candidate 10, thank you very much.
Yes, can you hear me?
11, this is a case of Crohn's disease. This is an MRE study. 2 sequences have been given to you. This is a T2 weighted sequence. This is a post-contrast sequence. What are your findings, please?
Selected images of MRE. It shows the mucosal hyperenhancement pattern, which is a sign of activity in Crohn's disease. There is vasa recta with fat stranding and engorged vessels.
And what is happening here? For example, here.
There is a vistulous tract with anterior colic fistula.
Okay, so this is an MRE study where there is a long segment stricture with acute inflammation involving the terminal ileum. Maybe portion of the cecum is also involved. As correctly pointed out, that there is hyperemia. This is that Coombs sign. You can see multiple loops which are adherent, possible fistulae, ileo-ileal fistulae. So here I am going to teach you a bit about MREs. Please remember that MREs now are bread and butter in the exam, and many a times they have come in the exam. In MRE, what we do is, for example, in my department, we are using mannitol, but you can use many things, and about 10 different things have come in the literature where people have used juices, milk, and many things, but we use mannitol. And basically, we give about 1300 ml of mannitol over a span of about 90 minutes or so. The idea is to distend the small bowel with fluid, and we give then buscopan, and we do scanning. The sequences which we do include T2s, 2 different types of T2s, and we do a fat saturated T1, and then post contrast we do coronal as well as axial. What a key sequence for you to remember, which is a Viva case, is the DWI. In DWI, what we do is that we do 4 kinds of DWI. This is B0, so the B value is 0, B50, B500, B1000. There is a bit of typo here, so this is B1000. Please remember that there is no hard and fast rule, and various departments use their own parameters. But this will give you an idea. You are increasing the B value. That is the main point. There is a lot of literature about how do you differentiate between fibrotic stricture versus an active stricture. And this is a Viva question also. And the answer is a DWI sequence. Now, if you look here, there is a stricture here and it enhances on post-contrast. Please remember, a fibrotic stricture can also enhance, though it will not be very thick, etc. But on a DWI sequence, there is a black and white difference between a fibrotic or an active stricture. And so here, this is from literature, where you can see restricted DWI, high signal on DWI and low signal on ADC map. This is a very important Viva question, and this is a very important question in your day-to-day life, where surgeons will ask you in the MDT that is it fibrotic or not, because if it is still active, the patient might still be a candidate for what we call medical treatment. If it is fibrotic, then it is surgical treatment. So candidate 11, if you can tell me, there is a stricture here. This is T2 weighted sequence. This is post-contrast sequence. So we were worried if it is active or fibrotic. B0, B500, B50, B500, B1000. What is your inference?
Okay, this visual tract show low signal intensity on T2. I couldn't see fair contrast enhancement, and it shows no restricted diffusion. So I think this is a fibrotic stricture.
Okay, so the idea here was to teach you how to infer the diffusion weighted. What you do is you look at the finding on B0, then look at the same finding. So this is that stricture, right? Many things are high signal on B0 because anything which is high T2, which will be high on B0, as the diffusion weightage is scanned, just concentrate here. Then B500, just concentrate here. And B1000, and still it is showing restricted diffusion. So the answer is that this is an active stricture. So the take-home point was that how do you pick up restricted diffusion? This is how it should continue showing high signal on the highest B value. Please remember the same concept we will see in liver imaging also, where we increase the B values, and we will say restricted diffusion when it continues high signal on the highest B value. Okay, this is your last film. Now, this is a spot film of a barium meal follow-through. I just want you to describe if there is mucosal thickening or not. Over to you.
Yes, there is a mucosal thickening.
Can you describe radiological findings? How will you describe in the exam?
Okay, there is spiking from the mucosa, and there is like putting of contrast, like there is a fistulous tract. I couldn't identify this bowel loop. However, there is a thickening and there is a spiking with thumbprinting appearance.
Excellent. Well, thank you very much, number 11. Next will be number 12, but let me take over on this case. Now, go back to the basics, and this is the idea here is to develop your eyes. How will you describe it? This is a vulvally conventi. Now, in between these two, the villi, in between these two is this space, so the barium will go in. So look at this loop, the barium will go in, and this is the thickening of, so this shelf-like opacity is the fold itself. Now here what is happening, this fold is thickened and this fold is thickened. So I will change to arrow to be able to show it to you clearly. Now this shelf here is the thickened villi, and this one is another one. So the spike of barium, which is in between, you can see that it is narrowed. So these thickened fold, thickness of the fold has increased. Second point is, as very well pointed out by candidate 11, that this is the mesenteric border and this is the anti-mesenteric border. If you can see here, these are thumbprints. And thumbprinting will always be more common on the mesenteric border, right? So this was just to develop your eyes on this finding. In your previous Chapman, there was differential diagnosis, rather two differential diagnoses, thickened fold in non-dilated small bowel. And we are in that territory. It's quite a non-specific finding, but you have to, sort of develop your eyes. This is a case of hypoalbuminemia of any cause. If you go here, you see this edema, hypoproteinemia. So hypoproteinemia is the most common cause which you will see, where you can see these thickened fold. So this was just to develop your eyes. Another case, and this is eosinophilic enteritis. So nobody is going to show you in the exam, but I wanted to show you an example of similar thing on an MR, where if you go back, you see this thing, eosinophilic enteritis. It's not a FRCR 2B case, eosinophilic enteritis, but this is just for differential diagnosis. And in this, you can see the same finding here, and same finding here on an MRE also, thickened folds. This, on the other hand, is a case of celiac disease, and it is interesting because similar to what we have picked up earlier today in barium meal follow-through, you can see that the proximal jejunum hasn't got, this is jejunum, no mucosal folds. And more distally, look at the ileum, jejunization, look at the ileum. So this is MRE of similar case. Now, if an examiner has got a good MRE examination, and particularly with a tumor, etc., might show you. So you might pick up the tumor, and then the question will be, what is the association and things like that. And the eye see what the mind knows. So this is why I'm showing you this example, that celiac disease can also come as a sort of a on MRE. Right. So those of you who are leaving now, if you can, the feedback is form is here, and if you want to scan it and complete the feedback. Yes, please. Number 12. Number 12. Are you with us? Okay. Now, number 12, I cannot. Have you raised your hand, number 12? Yeah, I can now see you. Yes, number 12, are you with us?
Yes, I am, yeah.
Okay. Now, this case has got, this is post-radiation change. There is a stricture here. What do you think is happening here? How will you describe this?
So on the spot images from a barium meal follow-through, the valvuli convenientes, they appear to be, there is thickening of the mucosa, and I can see the valvuli convenientes where you've been marked with the pointer, and some thumb printing as well.
Thumbprint
some
is also very good.
yeah, and mucosal fold thickening and some irregularity in the mucosa as well.
So my
And
question is regarding the concepts. This case is a post-radiation case.
yeah,
How do you explain all of these findings in post-radiation?
it's a fibrosis as a result of radiation.
Okay, so let me tell you, if you remember this concept, you can make your radiology. It's basically, it is vasculopathy. You know, small vessels, they are affected by radiation, and it is an ongoing process. So it's an acute over chronic process. And when there is an acute process, what will happen? The capillaries will become leaky, or there can also be intramural hemorrhages because capillaries might leak blood. And because of that, you can see these mucosal thickenings, like this, and also thumbprints. And then there will be chronic changes where you will see fibrotic stricture. Now, post-radiation change has come in the exam again and again and again. And in this particular case, you can see that there are long segment strictures. Candidate 12, do you think that these are malignant stricture or benign stricture? Appearance-wise, I mean to say.
So the bowel loops appear featureless, and I can see multiple strictures, and they're quite, at few points, they're quite long strictures and they're irregular. I can't see any typical shouldering in them. So I'm thinking that as there is a history of radiation, this is likely radiation-induced strictures.
Right. And what do you think about this loop here? Is there a bit of mucosal thickening?
Yes, there is mucosal thickening there, yeah.
Right. And what is happening here? Is there a bit of obstruction?
Yeah, proximally the loops are dilated as well.
Okay, so now this is a classical example where you can see chronic changes, you can see a bit of acute changes, and this all fits in radiation. So please remember that radiation changes just go on and on and on. So both things can go together. Okay. Can you describe this?
Yeah. So I'm presented with a barium meal follow through, and I can see that there is a long area in the terminal ileum, which is narrow, and there is also mucosal thickening in that area, and proximal to that there is some bowel dilatation as well, and mucosal fold thickening.
Okay,
and
can I stop you there? This loop goes like this and then goes like this. Yeah. Why do you think something can happen here, or something?
There could be a big mass sitting there, which could have displaced the bowel loops,
yeah,
and causing disappearance.
What is this?
So again, there is a soft tissue density that is sitting in the on the right side of the abdomen, displacing the bowel loops, and I'm just thinking. And it's in very close proximity to the small bowel. It's in the mesentery, I'm thinking. I'm not sure. It could be. It hasn't got any desmoplastic reaction, hasn't got any calcification within it. I'm just reaching up to the abdominal wall, and there is surrounding bowel wall inflammation as well.
So conclusion?
So could it be an inflammatory lesion there? It doesn't look like a collection.
Okay, so I'll take over. You see, this is lymphoma. Now, please remember that if you see thickened loop, long segment, and things like that, lymphoma is indifferential. Now, what is happening? That the lymphoma is sitting in the mesentery, and from the mesentery, it is going into the adjacent loops, and it will cause this thickening and all those things. Now, you did well where you wanted to rule out a carcinoid. But the point is that now look at this case. I hope it is projecting for you. Case 20 is projecting.
Yeah.
Is it projecting for you,
Yes.
CT scan? Okay.
Yes,
Now,
it is.
if you
Yeah,
concentrate on this case, and this is a very important concept which you have to remember, this also is a case of lymphoma. And here, what is happening is, it will tell you that this soft tissue is a lymphoma. You did well in your case where you were trying to rule out a carcinoid. And carcinoid classically will also cause desmoplastic reaction. There might be calcification. But what happens? This lymphoma is sitting in the mesentery, and you can see how there is, striations around it. So this, you can see that it must be causing a bit of lymphatic or venous obstruction. And with that, you can see the adjacent bowel loops here, and why it will cause thickening, mucosal thickening. Here, look at this loop, and there is a bit of thickening of this loop. So anything which is sitting in the mesentery, particularly lymphoma, also carcinoid, can cause these kinds of abnormalities. Now, we go back to thickened mucosal fold in, I hope it is projecting for you this.
Yeah.
Okay. Thickened folds in non-dilated small bowel, and lymphoma is one of them. Okay, now you have picked up something sitting here, right?
Yeah.
And maybe something sitting there. And you already know that on the CT scan, what do you think is happening?
It's a desmoplastic reaction. I can see some stranding around the lesion, and then there's a stranding in the mesentery as well, and the bowel loops are pulled towards it. So it's a desmoplastic reaction, likely could be secondary to a carcinoid.
Okay.
Or a lymphoma.
Yeah, that's well done. I'll take over. Now, carcinoid is one of the most important exam case. Again and again and again it will come. Please remember that carcinoid in the GIT, the most common site is small bowel. And within the small bowel, the ileum is the most common site. You have to know the concept. Histologically speaking, basically it is an intramural tumor. So, and instead of projecting into the lumen, it might project into the lumen, it goes out into the mesentery, number one. Second concept is that if the tumor is more than 2 centimeter, 90% of the times when it presents to us, it has already got metastasis. Two metastases are important for you to remember. One is within the mesentery, and second thing is liver. If it is in the liver, it will be enhancing, arterially enhancing, and showing washout. And mesenteric lymph nodes, mesenteric metastasis might be larger. Very important point to remember. It might be larger than the primary lesion. So the examiner can show you a mesenteric mass and where is the primary, and the primary might be more subtle a small bowel. So that is the take-home point. So then what happens is that carcinoid will 80% of cases it might show a bit of calcification. Second thing is that carcinoids, they produce serotonin or kallikrein, because of which there is desmoplastic response, and there will be constriction of lymphatics or venous system, and the adjacent bowel loops might show a bit thickening. This is classical for carcinoid. And I have got a very, very good case here, classical exam film. I am conscious of time, but I think we'll continue for another 10 minutes or so. I know that it might be too late for people outside UK, but this is exam season and I think we have to crack on, because I want to finish small bowel today. So maybe another 10-15 minutes. So now this case is too good for me not to show you. So it's a classical exam film and a beautiful case, and you can learn a few points from this one. So candidate 12, can you see this PACS case 5?
Yes.
On your...
Yes, I can. Yeah.
I will. My God, sorry for that. I have actually shared a wrong screen with you. Are you seeing this barium?
Yes, I can see this barium. Yeah.
Okay, all of you, if you can concentrate on this classical exam film, for a long case. On a barium examination, you can see this filling defect. Subtle but definite, because it is persistent and you can see loops here. And then on a CT scan, one thing is that there was a metastasis in the liver. And on these films, it was missed. Why was it missed? By the way, all of these are simple cysts. There is a metastasis which is sitting actually here where I'm pointing out. And this is just a portal venous phase. And key learning point here is that in the end, I will show you a liver window, and on liver window, you will see it. So that's the point to remember, but I'll come back to this metastasis. Now, as we go into the mesentery, you can see this mass. And with this mass is a bit of calcification. And you get excited that this is the primary lesion and you call it a carcinoid. And the examiner wants, okay, where is the primary? Actually, the primary is sitting here. You remember that barium? And this is classical because this is the primary, and this is an example where the metastasis is larger than the primary, and this is a usual behavior. And if you go to coronal, you can see it looks much bigger. That the metastasis in the mesentery, but look at this primary, and the primary is much smaller. Now let me show you that liver abnormality, and this on an MR then proved to be arterial phase enhancement and then washout. So this was a metastasis. If you go back to the CT, and the learning point is always look at the liver window. And there is a lesion here, very subtle, but if you go to the liver window, which is width 150 and level 188 on our CT scanner, on our PACS, should I say, this is the liver window. So that's another learning point. Okay, we crack on with okay. This number 12, you are still with us.
Yeah.
Okay, so you will continue till the end because we are just close to end. There was a lesion here, which is,
Yeah.
and on a CT scan, what do you think it is?
So on a CT scan, yeah, I can see that, and I can see some barium within it as well. So is it like a diverticulum?
Actually, what has happened is that there is a mass within within the lumen, and this mass has got, the key here is, because of time I'm I cannot give you in a viva format, but classical exam case, it is causing after 6 months it is causing a bit of intussusception. If you see the mesentery is going in, please remember that people think that intussusception is always acute. It can be chronic and it might not be clinically evident. It is a degree actually intussusception. Basically, the take home point is that this is a lipoma, and the key here was in the viva that fatty density, and the key thing was to see the Hounsfield unit. But what I am showing you that in an adult, whenever there is a bit of intussusception, you can see mesentery being pulled into the lumen. There must be a lead point. Okay, what do you think is happening in the mesentery?
So the mesentery appears misty in this one, and there is generalized increased attenuation in the central mesentery, and there are some enlarged lymph nodes as well, I can see. And I think this is just so this could be could be paniculitis, mesenteric paniculitis, or could be secondary to any inflammation.
Okay, very good. Now, that's very good. Now, mesenteric paniculitis is a very important exam case. Why? This is the current concept is that we now call it IgG4 related disease. So there is a spectrum, and in radiographics there are a few good articles, and Google New England Medical Journal and radiographics. I think there are 3 very good articles there. Read about IgG4 related disease, and this concept only came in 2012, if I'm not wrong, because now we have got, and why is it important for you for your exam? They will ask you long cases from the same concept. Previously, many things which we could, we were sort of our concept was that these are unrelated to each other. Now we know, and there is a huge spectrum. Retroperitoneal fibrosis, mesenteric paniculitis, let's say autoimmune pancreatitis, sclerosing cholangitis. There can be nodules, in kidneys and liver, etc. Thyroid orbitopathy, what we used to call pseudotumor of the orbit. Pseudotumor of the orbit. All of these things, they are in IgG4 related disease, and they will show you long cases. And here, the take-home point is that if you see here, classical description is that in the misty mesentery, you will see fat surrounding the vessels, but the fat will not displace the vessels. Fat will not displace. Another thing, please remember the concept that the concept of the misty mesentery is that there is a bit of fat necrosis, and you can see these soft tissue nodules. These soft tissue nodules, radiologically speaking, they look like lymph nodes, but they might not be lymph nodes because they are foci of necrosis which give you this appearance. And in my experience, we have done advised some laparoscopies for a few of them, and when the surgeons they go in, they don't see anything. So there can be lymph nodes and there can be explanation, which I have just told you. So this is from your previous Chapman, mesenteric paniculitis, 6.31. And this is another case, milder case, candidate 12. In this case, there is, if you can see that there is a soft tissue lesion with some calcification in the mesentery. With that, there is something around the aorta. What will be your differential? Long case. It's a long case. I'll show you another film for this.
So there is a soft tissue around the aorta and some calcification within the lesion. Could this be some inflammatory, like fungal? No, there's not aneurysm here.
So I'll take over.
Sorry, I don't know.
Yeah, basically it is a case of IgG4 related disease. This soft tissue there is basically retroperitoneal fibrosis. With that, there is sclerosing mesenteritis. Please remember the spectrum. What happens is, the case which I showed you initially is more acute, but gradually there can be fibrosis and there can be calcification there. So calcification with surrounding soft tissue within the mesentery, the top differential diagnosis include mesenteric paniculitis or IgG4 related disease, which will be slightly more chronic. It can also be seen in carcinoid, as you have already seen. It can also be seen in treated cases of lymphoma. Please remember, treated, not untreated. So one can infer that this might be, treated lymphoma. So 2 + 2 makes 4. And the same case can be given with findings in the orbit, which we'll cover in the head and neck. But having said that, this is, again, the same differential, lymphoma versus IgG4 related disease. Take home point is that orbital pseudotumor, the old terminology, is now no more used. This is a case of interception on a barium examination, right? Can you describe the findings to you? I have given you the diagnosis.
So there is a filling. There appears to be a filling defect in the bowel wall. I can see that the bowel wall, that is very smooth filling defect, and it appears to be that there is narrowing of the proximal, and there is some dilatation of the distal bowel as well. So these findings are inconsistent.
Excuse me. What is this?
So this is the bowel which is telescoping into the other bowel.
Okay. Whenever you find, I'll take over. Whenever you find interception in an adult, think about a tumor. I have showed you a case of lipoma. We call it a lead point. Always look for a lead point whenever an adult comes to you with interception. In children, of course, it's different. Now, if you see here, there's a filling defect here, and this proved to be later on a metastasis. That is not my point that you call it a metastasis, you call it a mass. What is happening that this is the interseptum and this is interseptions. So this loop is going to telescope into this. If you see the lumen of this interseptum, this is the lumen, and rest of the, of course, there is a bit of constriction. There is a bit of barium in between the wall of the interseptum and the interseptions, and which is giving you this spring coil appearance. So this is the lead coil. So I have shown you this just to develop your eyes. This will be an easy case for you. And what is happening?
So there is a small bowel dilatation of the small bowels, along with a laminated calcific density in the small bowel loops as well, and some surrounding inflammatory change and thickening of the bowel wall. So this is small bowel obstruction secondary to mass with a calcification within it, likely some gallstone.
Okay,
sitting
so
there.
if you see here, this is, if you see gallbladder here, it is fistulating into the duodenum, and then it has gone, this is the stone here, and there is small bowel obstruction, classical case of gallstone ileus. Is number 2 with us? Number 2? Okay, I am going to, yeah. Thank you very much, number 12, very well done.
Thank you.
Number 2?
Yep.
Okay, I thought that I'll finish, but I've got still a few films. We'll crack on. So motivation is the key in exam, and I know it's 9:15, but we will finish it, whatever is left. Spot diagnosis, what is it?
So it looks like an outpouch in the wall. So it's a diverticuli.
So which border is it? You see, this is ileum. This is the mesenteric or the anti-mesenteric border.
This anti-mesenteric border.
So take home point. What is it? And give me the diagnosis.
Scleroderma.
You see, this is the anti-mesenteric border. This is the ileum. This is correction. This is the anti-mesenteric border. This is the mesenteric. Right. And this outpouching is just maybe, you know, small outpouching. And look at the mucosa. You know, it gives you this V-shaped pattern here. The point is that this is a slam dunk case of what? You know it. Anti-mesenteric border, Meckel's diverticulum. Whatever is written here are potential viva questions which have been asked in the exam. And these concepts have come in the exam. Please remember that Meckel's diverticulum, this rule of 2 you must remember. Seen in 2% of population, located in 2 feet to ileocecal junction, length of 2 inches on average, symptomatic usually before age of 2. This is a point to remember. Usually in children they will be symptomatic. But in adults, the main complication can be diverticulitis or intestinal obstruction. And the concept is that 50% of them contain ectopic gastric mucosa and 90% present with GI bleed in children. So in children, it is important. Okay, number 2, what is the investigation of choice here?
So you can do a Meckel scan, which is
Excellent.
a type of.
Right. So this, of course, I don't know much about nuclear medicine, and this will be covered later on by one of our colleagues in your nuclear scan session, but they ask it. It has come in the exam many a times, and you should know this. Technetium-99 per-nitate scan is done, and it will only be positive if gastric mucosa is there. Otherwise, it will not be positive. And how much? 50% has got ectopic gastric mucosa, but in symptomatic children, usually 90% of them will have it. Meckel's diverticulum on a barium study, Meckel's diverticulum causing an intussusception. Okay. Yes, please.
Okay.
If all of you can concentrate, it is very, this is a very good case, and many films have come in the exam from this pathology.
So, so the bowel appears to be significantly dilated and folded in together with multiple folds, with a smaller distance between them. The bowel also appears to be of larger caliber than would be expected. And I think I can see some circulations on in the right upper quadrants.
Okay, what is your conclusion?
So the appearances are typical for scleroderma.
Okay, very good. Now, let me tell you, scleroderma is a very, very, very important exam case, and it is You know, in MSK, you remember we did a lot of scleroderma for calcification and things like that. And similarly, GI involvement films come. Please remember that GI-wise, the most common organ is esophagus, but films-wise, they will not show you. They will show you, enema is very common where you will see circulations in the transverse colon, etc. But in small bowel, two types of findings can be seen. First of all, let's go back and see the pathology. You remember that there is muscularis propria in the gut. This muscularis propria, which is the smooth muscle of the gut, it is replaced by collagen and fibrosis. This is what is happening in the small bowel. And because of that, in the small bowel, there is a particular pattern which can be seen here. You know, because the circular muscles are affected, there is loss of capability of elongation of the bowel. At the same time, there is no loss of capability of dilatation. So there is crowding of folds in a dilated bowel loop of the small bowel. It is absolutely pathognomic. No other condition in the world can cause this. Please remember, if there is dilatation, there also will be increased distance between the folds normally. But this is a unique one where there is dilatation, but there is crowding of folds because of the concept which I have told you. So this film you have to remember. Second thing is that what can happen is that because of fibrosis, there can be outpouching of the bowel walls, and these outpouchings are more clearly seen at times in large bowel also. So these two findings are pathognomic for scleroderma. This appearance is known as hide-bound bowel appearance, synonym with hide-bound appearance of the skin of the patients, where it is just like cattle because it becomes very hard. And if you see here, the same finding on a plain film can also be shown. This is what we call pseudo-seculations, where this is the mesenteric border, this is the anti-mesenteric border, and you can see these localized bulges. Remember that this is fibrosis, and because of that there is bulges, and this finding can also be seen in the large bowel. Spot diagnosis. Number 2. What is happening here?
So there's multiple sacculations with thickening of the small bowel.
Which border is involved? Mesenteric, anti-mesenteric?
Mesenteric border. And mucosal irregularity.
So I'm not interested in mucosa. So your finding might be there, but what is this? You can see a neck hair, this. Okay, same case, CT scan after 1 year.
So there's some ischemic small bowel loops with 3 gas locules.
Why do you say ischemic bowel?
Doesn't appear to be enhancing.
You see, these loops have got contrast. So the point is that look at the mesentery. Okay, let me give you a hint. If this was sigmoid mesentery and there was stranding there and there were locules, how would you have called that?
Also, it's divertically of these.
Yeah, diverticulitis. So here, please remember that diverticulosis in the duodenum can also happen. And when there is diverticulosis of the duodenum, it will be on anti-mesenteric border. And the diverticuli do not have the muscularis inside. So whatever food goes in, can stay there unless gravity-wise it comes out. So just like sigmoid diverticulitis, you can have jejunal diverticulitis. And then within, so this is not free air, this is air within the mesentery. And classical findings of jejunal diverticulitis. Okay, last few films. This is a case of ischemic bowel. What is the key finding?
Okay, so there appears to be some gas in the bowel wall.
Okay, I'm not interested. Anything else?
The bowel wall appears to be thickened.
Anything else? So what I'm trying to teach you is that when you get a case of ischemic bowel, there will be, which is a very important exam case, there will be pertinent negatives and positives. So you have done well where you pick up if the bowel is dilated, number one, if there is thickening, if there is nematosis, if there is perforation, and in that category, what will be your pertinent negatives or positives? So some of them you have already pointed out. What is left now?
Okay, so there's thrombus in the SMA.
Excellent, well done. So always look for the big vessels and particularly SMA. So you can see that there is complete occlusion of the SMA. What is the finding? Ischemic bowel again. Pertinent negative or positive?
So hyperenhancement of the wall, gas in the wall of the small bowel in the pelvis, some free fluids.
You see, this is what we call small bowel, that string of pearl sign or string of bead sign. And this sign means that there is bowel obstruction. Anything else?
There's locules of gas within the pelvis, sort of inferior.
Yes, no, I'm not interested. That is, intraluminal in the large bowel.
Okay, the bowels also become featureless. There's a lot of fat stranding.
Right. The main thing is that if you see here, I wanted you to pick up this discrepancy. Look at these loops and it shows normal enhancement of mucosa. These loops are not enhancing. So other than nematosis, perforation, large vessels, always try to look at the bowel wall also. And you might get this kind of finding. In this case, when laparotomy was done, this was 8 feet of bowel which was necrosed. And this is from your new Chapman, small bowel wall thickening and divided into 3 less than 6 to 40 and more diffuse. So have a look at this one also. This one is slam dunk. You have already covered it. You have seen similar cases, which is nematosis because of small bowel ischemia, portal vein gas. Last case of the day. 28-year-old male, motorcycle accident, multiple limb and chest injuries. Over to you. So this is the last case of the day. Those of you who are still with us, there are 500 people. Good. So if you can concentrate on this one, this has come in the exam quite a few times.
Okay, so there's hyperenhancement of the small bowel, which appears to be thickened, and there's also hyperenhancement of the adrenal glands with relative hyperenhancement.
Excellent. So what is your conclusion?
Shocked bowel syndrome.
Okay. So shock bowel syndrome is given here in your Chapman, diffuse more than 40, and these parameters should be in your knowledge. And I have seen in my experience many times candidates mix it up. They think that there has been what we call contrast in the bowel. No, there is no concept of contrast in a trauma case, right? Nobody has got the time to give contrast. So because it enhances like this. And these are the signs from literature which have been given for shock bowel. Hyper enhancement of adrenal is a bit of a subjective phenomena there, and similarly kidney. But always look for IVC and IVC, collapse of IVC. There are some measurements also if you read a good article in radiographics, but there is no need for the exam. Basically, aorta is small, IVC is small, chalk bowel, and this will be a finding which you might see in association with other things. So please remember that. And if you see a trauma case, always look at the small bowel and even make it as a pertinent negative for your exam. So thank you very much. Sorry, I think we 30 minutes over time. So in any case, Viva format actually takes a bit of time. So I urge you to must do these feedbacks forms, which is the only thing which you can do for us, because the more feedbacks we get, the better it is, and no teaching is without feedback. So please spend a few last minutes